Hello, dear colleagues and friends. Today, I would like to feature a new case from the ASAS online case library. This is case number 27. As you see, we have here a 25-year-old male patient who presented to a rheumatologist because of back pain and suspicion of axial spondyloarthritis. Back pain started slowly about 1 year ago. There is improvement of pain with exercise, no improvement with rest. There is night pain with improvement after awaking and doing some exercises, and morning stiffness of about 30 minutes. There is no alternating buttock pain, but the pain responds well to non-steroidal anti-inflammatory drugs. So overall, we would say this is a back pain of inflammatory type. In addition to back pain, there is bilateral arthritis of knee joints and no enthesitis or dactylitis. We also couldn't find any indicators of the presence of uveitis, inflammatory bowel disease, or psoriasis, but the family history was positive. Father of the patient is suffering from ankylosing spondylitis. On a clinical examination, there was some tenderness over the left sacroiliac joint, normal spinal mobility, and both knee joints were tender and swollen, corresponding to the already known arthritis. No enthesitis or dactylitis, and no signs of psoriasis on objective examination. In lab findings, HLA-B27 was positive, CRP was slightly elevated, as well as ESR, and there were no abnormalities otherwise. So as you can see already at this stage, we can make a diagnosis of an inflammatory condition, most likely of spondyloarthritis, because there is B27 positivity in a young male patient with oligoarthritis affecting predominantly lower limbs. So the question will be, is there also axial disease? Is there also inflammatory involvement of the axial skeleton? And for this reason, we need imaging to find objectively whether or not sacroiliac joints and spine are involved. We started with X-rays of sacroiliac joints. As you see, this is a Ferguson view, so we can judge on the entire sacroiliac joint, including the upper part of the joint. And what you can see here, there are no major abnormalities here, so definitely no clear radiographic sacroiliitis. So in this case, we still suspect axial SPA. We need to go for advanced cross-sectional imaging, and in this case, the preference should be given to MRI. MRI was performed, and what you see here, this is stir sequence in semicoronal plane, where we can look for active inflammatory changes. This is a water-sensitive sequence, and you see it on bright fluid, bright signal from water-rich structures like spinal canal, healthy intervertebral disc, and fat is rather dark, subcutaneous fat tissue is dark. What you see here, you don't see major impressive findings, but in the left sacroiliac joint, there is some subchondral bone marrow edema localized in a typical anatomical area, so subchondral bone, mid part of the joint, and you see it goes through many slices. So this bone marrow edema is present on several slices. This finding is, of course, not very impressive, and normally, if we talk about bone marrow edema in general, this could be rather unspecific finding, unspecific bone marrow edema induced by mechanical stress. And therefore, it is extremely important to look at the context of this bone marrow edema, whether or not there are also structural changes available, structural changes compatible with axial spondyloarthritis. For this purpose, we need at least T1 weighted sequence. You recognize T1 on dark water signal and bright signal from subcutaneous fat tissue. And what you see here, you see some structural changes indeed. So there is some subchondral sclerosis surrounded by fatty lesions, fat lesions. You see also here some fat signal in the bone marrow and small bony defect corresponding to an erosion. And on the right side, there is another one, a very small lesion, but in fact compatible with erosion with the surrounded fat lesion in this joint. And if you look carefully, then you might find also a bright signal in a projection of the joint, and this is something we call nowadays backfill, and this is repair tissue, granulation tissue filling out erosion, so stage of repair process leading finally to bony buds and to the ankylosis. So this patient has two highly specific features compatible with spondyloarthritis: erosions and backfill sign, in addition to some fat lesion of bone marrow and subchondral sclerosis. And on this background, the interpretation of this tiny bone marrow edema would be highly suggestive of spondyloarthritis. There are also some additional sequences, MRI images from the spine, and what you see here, there is no spine involvement in this case because this is a rather early case, so there are no definite inflammatory or post-inflammatory changes. We also included MRI of the knee joint. Patient presented to us where you see quite impressive infusion. That's it. So why this case is important? This is a rather early case of axial spondyloarthritis at non-radiographic stage because there is no structural damage visible on X-rays. And in this case, we see not that much bone marrow edema. And the interpretation of bone marrow edema we observed here was done in the context of structural lesions and of course in the context of clinical information, and only the background information resulted into a clear interpretation of this bone marrow edema as highly suggestive of spondyloarthritis. And finally, all together, this resulted into the diagnosis of axial SPA. That's it from my side for today. I hope to see you soon in the future.